Welcome to this meeting of the Health Overview and Scrutiny Committee. I'd like to inform those present that this meeting is being webcast live and will be capable of repeated viewing. In terms of procedural business, I'd like to seek any declaration of substitutes.
Substitute for Jackie Okui, Councillor.
Councillor, I'm also aware that Councillor Gilmont will be substituting for Councillor Mackie today, and I've also had apologies from Councillor Hogan and from Councillor De Oliveira. Do any members wish to declare any interest in relation to any matters included on the agenda? I don't see any declarations. I'll now move on to exclusion of the press and the public. We have no part 2 items today, so the press and public won't be excluded. Our next item on the agenda is the minutes of the meeting held on the 23rd of April 2025. The minutes of the HOSC meeting are here for approval. Do members agree to the minutes? Thank you. I now turn to my chair comms. This is the first meeting of the HOSC since our May annual council meeting and my first meeting as chair. I'd like to express my thanks for all the work done by the previous chair, Councillor Teresa Fowler. Some committee members have also changed, and I'd like to welcome Councillor Sam Parrott and Councillor Jackie Simon to this committee. Welcome. We have 3 items for discussion today. The HOSC had a report in November 2024 on what the Sussex Health and Care System planned to do to manage additional demand across winter 24-25. Partners have come back to committee today to update members on how the system coped and what lessons have been learned for future years. In September 2024, the HOSC held a special meeting to look at Sussex Partnership Trust plans to close its specialist inpatient dementia ward at Millview Hospital, repurposing the space as an acute mental health ward. The Trust is returning to HOSC today to provide an update on how these plans are progressing. We also have a report on children and young people mental health services. I know this is an issue that is of concern to HOSC members and to many families across the city. Young people's mental health is also a Sussex and Brighton and Hove priority for improvement, so I think it's important that the HOSC has opportunities to hold partners to account for their performance and to learn about improvement planning. In addition, there have been lots of recent national activity in the NHS which will have local implications. There was a letter from Councillor Hill about changes to the integrated care boards on the agenda today. We have also had the publication of the NHS 10-year plan. I will ask the members to be briefed on this important strategic document in time. Some of you may already have seen that Dr. George Findlay, CEO of University Hospital Sussex NHS Foundation Trust, has just announced that he will be stepping down as Trust Chief Executive. I would like to take this opportunity to thank George for his engagement and positive interactions with the HOSC. He has consistently found the time in his incredibly busy schedule to attend meetings and to answer our many questions with patience and good humour. We've also recently learned that it is likely that both Healthwatch England and local Healthwatch organisations may be abolished. This is concerning news. Healthwatch Brighton and Hove provides really important services locally, ensuring that local people have up-to-date information about health and care services, sharing people's experiences and services with commissioners and providers, and supporting individuals to navigate their way through a very complex landscape. I know that members of this committee, as well as many other local individuals and organisations, feel very strongly about the abolition of Healthwatch. And if members feel it would be helpful for me to write to the Secretary of State on behalf of the committee, I would be happy to do so, and will ask support officers to coordinate this. Thank you. Finally, I know many people are worried about the tender process for primary care services for people living in Whitehawk. These services have been provided by Wellesbourne Healthcare Centre, but the contract is currently being re-tendered. This is a live tender process, and there are legal restrictions which mean that the commissioners and the potential providers of the service are currently unable to discuss details of the contract or the tender in public. This is frustrating, as I know many people have questions that need to be answered, but I recognise that the legal position is clear. I will nonetheless consider whether there is anything that this House can do in the short term. I am conscious that if we wait until commissioners are able to talk to us, the contract will have been awarded and it will be too late to make concerns now. Thank you. I'd just like to inform the meeting that we have no public questions at this meeting. And I'll now move on to member involvement. As I mentioned earlier, we have a member letter from Councillor Hill, and I'll ask Councillor Hill if you would like to briefly speak to your letter.
Thanks. Would it be helpful if I read out my letter? Yes. So, dear House members, since 2022, Brighton Hove has been part of the NHS Sussex Integrated Care Board, one of 42 ICBs in England. As part of the plan to abolish NHS England, funding for ICBs is being cut by 50%. The chair of NHS Sussex, Stephen Lightfoot, has put forward plans to merge the Sussex ICB with the Surrey Heartland ICB to realise cost savings necessary to make this 50% cut possible. This is based on the need to now operate within an annual cost of £18.76 per head of population, which is not possible within the current ICB framework. I'd therefore like to have a future item to this committee which would allow us to ask questions of senior members of the Integrated Care Board so as to help us and the public understand the implications of this change. This is likely to have wide-reaching consequences. I have concerns such as a large integrated care board means that this could be leading to a lack of local connection. There will be issues with the new Sussex Strategic Authority boundaries, which would not be coterminous with the new ICB proposal. And just be clear, the Sussex Strategic Authority is what the mayor would sit on, be representing on. So I've attached a letter by Stephen Lightfoot, which goes into more detail, which I recommend members read. I'm not really asking that we all need to debate this. I think it's just something that would be appropriate for a future item, and I've heard reassurances already that that's likely to be the case. So, yeah, that's all I have to say. Thank you.
Thank you, Councillor Hill. I do agree that these are important issues, and I'm happy to invite NHS colleagues to explain the proposed changes at the next House meeting. I will also ask for this to include a brief explanation of the NHS 10-year plan and what this may mean for local people's healthcare. I would also like to note that all members of Brighton Council Overview and Scrutiny Committees should have recently received an invitation to a special scrutiny meeting on the 31st of July to talk about devolution and local government reorganisation with the leader of the council. How the emerging new model of local government in Sussex aligns with changing NHS organisational structures is certainly something we can discuss at this meeting. Thank you. Now move on to the main items on the agenda, the first one being the Winter Performance 2024-25 report. And I welcome Nikki Smith from the Integrated Care Board to present, and she will also introduce her co-presenters. Thank you, Nikki.
Thank you, Chair. My name is Nikki Smith. I'm the Director of System of Resilience for Sussex ICB, and I came here in November to present the winter plans for you. So I've come this time to present the outcome of the evaluation of the winter plan for 24-25. This was undertaken to identify really areas of success and recommendations that we can incorporate into future planning. It's part of our cycle of continuous improvement that's undertaken every year as a safety in order to improve our ability to respond to winter pressures going forward and maintain patient safety and patient experience. Both the winter plan and its evaluation are undertaken through collaboration with all system partners in Sussex, such as our acute colleagues, community and mental health trusts, the South East Coast Ambulance Service, our private transport suppliers, the local authority, patient representative, and our communications primary care, business intelligence, and system resilience team. So it's a wide review of every part of the planning that goes into winter. The winter plan covered the period from the 1st of November 2024 to the 31st of March 2025 and focused on 5 very clearly articulated key pillars. The first was prevention and case finding. The second was same-day urgent care. Then we had improvements in discharge to improve and support patient flow, sound operational management and oversight, governance and escalation. Each pillar was supported by a number of work streams working across all of those collaborative groups that I've mentioned before. Following the end of this period, the plan was comprehensively evaluated by both a provider survey, a winter plan evaluation debrief session with all system partners in the same meeting, and a comparison of the demand and capacity modelling against what actually happened in our actual performance. And then we had work streams under the pillars of self-evaluated achievement of their own aims and objectives that fed into that. The review clearly concluded that overall the winter plan met its aims and objectives. Although some areas of performance were impacted by a higher and earlier spike in respiratory disease demand than expected, the system performed really well in keeping patients well and maintaining both their safety and experience throughout the winter period in comparison to a number of national benchmarks. 2 key areas of particular focus for future planning, however, are the discharging of patients who no longer meet the criteria to reside, and managing the surge in demand that was over and above what we expected, caused by seasonal flu and COVID in early January. The key notable achievements that we've got in our report are numerous, but the key ones here are the ambulance waiting times. South East Coast Ambulance Service significantly improved their position for Category 2 performance, and the response times were faster than the national average, which really impacted on those people of lesser acuity being seen in a speedier time. The COVID-19 Vaccination Access and Equalities Programme was successful in reaching vulnerable groups and delivered vaccinations via a number of new and innovative services, especially in Brighton and Hove. Brighton and East Sussex also implemented an unscheduled care hubs in Brighton and in Polegate. And the initial analysis indicates that the hub provided clinical advice to paramedics and others responsible for patient care, which led to 824 fewer ambulance conveyances to hospital for Brighton and Hove residents. And that obviously is extended, is also more patients in East Sussex as well. Virtual ward capacity was increased over the winter period and exceeded our targets. The virtual ward capacity increased to over the 250 bed target, and we had 80% of virtual ward beds have been utilised, which had avoided patient admission into hospital and allowed them to be cared for by professional teams in their own homes. This ensured that patients are treated in the environment that would give them the best possible outcome. A number of practices signed up to the cohort identification and multidisciplinary team programme to support the management of patients who, using a risk stratification tool, were identified of higher risk of admission to hospital and increased GP appointments. So they were seen earlier and actually provided with more support in the community to prevent those admissions into hospital. The new integrated operational pressures escalation levels framework, it was implemented in Sussex significantly ahead of time, and we were the first system in the region to do so. This helps all healthcare providers determine their current level of operational pressure and whether or not escalation is required, and that can be provided in a timely fashion if needed. This feeds into another platform, which is called the System for Health and Resilience, which helps us to manage and respond to operational pressures within the healthcare system and helps identify areas of risk collaboratively in a timely fashion. And all of our organisations are actively utilising that. The system was well connected throughout the winter and was able to respond collaboratively to identify operational issues in a timely fashion and come together as a system to respond. Key targets that we've identified for future winter planning. We're looking to target specific areas of urgent and emergency care performance through a big programme of work currently underway, focusing on the priority targets, actions in the National Urgent and Emergency Care Plan, such as discharge, patients with long length of stay, no criteria to reside, and the A&E 4-hour target. We want to improve the awareness of respiratory disease and the expected impacts to modelling, so that we're better prepared as we go into next winter. Improve healthcare workers' uptake of flu vaccinations. We're working with all of the trusts to plan for this earlier, despite the cohorts not currently being part of the Joint Committee on Vaccination and Immunisation groups, and really look at staff engagement and try and manage that where we can. We're putting plans in place for an earlier for a reset event over Christmas and New Year. We ran that last year, and it was really helpful, but we want that to be started slightly earlier, and describing the outcomes and how they can be sustained over that period, really to look at that specifically difficult time over Christmas and early into the new year. We are looking to target specific audience and geographies to increase communications cover and get messages via people's preferred methods as we move forward. And building local area reporting into data monitoring is another area that we've identified to move on with next year. So overall, the Brighton and Hove system worked really well over the winter of 24-25 to meet demand for services. This is a result of really good joined-up planning and delivery across all of our partner agencies and organisations in health and care, including the voluntary sector. All of the recommendations included in the paper will be incorporated into the planning for winter 2025-26, which is currently underway, and we look forward to sharing that plan with you later in the year. Thank you.
Just to carry on from what Nikki has identified, I'm Tanya Brown-Griffith. I'm the Joint Commissioning Director for Brighton and Hove, working with the ICB. And one of the questions I think people would have been seeing recently is around the practices in terms of sign up. And I'm happy to say that Brighton and Hove had 30 out of 31 practices covered in the LCS that included the look at winter frailty, and also in terms of more preventative approach. So a really good drive in Brighton and Hove around prevention. And that was the focus of starting that last winter, which I'm happy to say that we are beginning to start the planning on prevention from now for this winter. And that includes proactively managing persons who are at risk of multiple long-term conditions, including respiratory, as Nikki mentioned before, but also frailty from not just an older person point of view, but a multiple compound. So we know in the city, for example, we have many people who are experiencing homelessness, perhaps drug and alcohol challenges, and require that additional support. So our ARCH medical practice, which focuses on that homeless or those experiencing homeless and challenges with drug and alcohol and mental health support, are also ramping up their in-reach into the hospital. The integrated team also includes, as you know, the CGL, which is the Commission Public Health Drug and Alcohol Prevention Service. Additionally, this winter, last winter and for this winter, we have done some local initiatives in terms of the integrated community teams, which I know we have presented a little bit of an update in previous HOSCs. And this is ensuring that we're integrating care at a neighbourhood level. So that includes working with our voluntary care organisations to ensure we have more uptake around screening, which we know is a challenge in Brighton and Hove, but also vaccination and other sort of uptake, flu and others. So I think we've got a really good lay of the land and what we need to improve on. We've got many areas that we need to improve on going forward. So your support in certainly the vaccination messages through your wards would be really helpful. The flu messages, we've really designed and developed easy read, accessible information in different languages. So your support in getting that out really early would be really valued. Thank you.
Thank you, Nikki and Tanya, for presenting that report. I'd now like to invite members to ask any questions they may have. Councillor Hill.
Thanks. You prefer, Chair, if I went just for one question or to ask all of my questions together?
How many questions do you have, Councillor?
3.
You can ask them all together.
Great. So one of the questions I wanted to ask was around the areas for improvement that's mentioned in the document. So it says that you're looking to increase the uptake of vaccinations around healthcare workers. So I'd be interested to hear more about sort of the causes of issues with vaccinations among healthcare workers, and then what plans there are to improve this. It says elsewhere in the document there's also 18,500 healthcare workers self-declared as either receiving a COVID vaccine or flu vaccination, which is sort of said it's a positive, but then it's also saying there's ways for improvement there. So I'm interested in hearing a bit more about that. I think it's also probably I'd be interested to hear more about plans around no criteria to reside. Obviously, we still are looking at, this is one of the worst, if not the worst in the country for amount of patients in that position. So I think we heard before from Dr. Findlay that was a key contributor to people in corridors, and those corridors being filled with beds because of people needing discharge. So be interested to hear what plans are in the sense of trying to resolve that. And then finally, I wanted to ask just about people coming into A&E with non-emergency mental health issues. This might be something that's a bit outside of your remit, but I'd be interested to hear if there's anything that's specifically being done about that and to address that issue. Thanks.
Thank you. I will hand the questions to those experts that are actually here, if that's all right. I will, Andy, can I pass that vaccination question, the staff vaccination question, over to you? Dr. Andy Hodson is here as our clinical representative from NHS Sussex.
Thanks, Nikki, and good afternoon, councillors. Sorry I can't be there in person. And thank you for your question. Regarding the vaccination, so specifically the question about health and social care workers, so there's a difference between whether COVID is in the JCVI, whether that will be offered within the government plans regarding vaccination. Flu will be. My understanding is that this winter COVID will not be included in that for health and social care workers. So the real focus will be on uptake of the flu vaccination. So what we're doing is today, in fact, if not tomorrow, then to be asking our provider colleagues and CMOs, chief medical officers, regarding their plans for that uptake for their staff. After all, they know their staff best. They know the best way to be able to vaccinate them, whether that be a pop-up clinic during working hours and so forth, to really get an idea of those plans for those workers, because it's essential really that the health and care workers get those vaccinations early on to protect them, protect their patients, and protect the workforce and the capacity for the healthcare system to continue through the winter. We saw last year there was indeed an early uptick in respiratory diseases in sort of late November, early December regarding that, and I think we correlate that to staff sickness as well. So really at this early stage, what we're doing is actually shifting much further forwards, i.e. it's only July, but winter comes upon us quite quickly. So we're getting those plans, making sure that those are going to work, if you like, and that we can offer any support to providers that need it regarding those plans as regards increasing the vaccination status of the health and social care workers. But the COVID side of it, I do not think is going to be included in the winter JCVI recommendations, which is what we have to abide by. So I hope that helps a bit. I'm happy to answer any more general questions on vaccination, if you like, if there's anything more specific, Councillor.
Just to ask on the COVID vaccines, is that a nationwide policy, the change around that? Is that based on that? Okay.
It is. We always have to follow nationwide policy on that, really, because that's where it's indicated for, and that's how the supply, if you like, is given as well. So we can't deviate from that.
Okay, that's helpful. And just to be clear, could you explain just some of the reasons for what the issue was in terms of the uptake of vaccination last year? Because I'm not sure I fully understood that.
In general terms, or for care and social workers?
For care and social workers.
There was a low uptake, and I think it improved. We did do some in-reach with, there was some sort of mutual aid and some in-reach from some of the GP Federation side into it as well. So that certainly improved the data. The data is not as clean as the data that we get from patients, because that is all recorded in the GP notes. And more broadly, the patient uptake for flu and COVID was a bit lower in Brighton and Hove than it was in the East or the West. And again, I think back to Tanya's point around as much help as we can get going into this next winter period regarding messaging, because I don't think it's an issue around access, to be honest. I think the access is there for patients. It's a matter of uptake, and interestingly, the over 65s, that number comes up significantly and nearer to the average from the East and the West for Brighton and Hove than for the cohort who is under 65, who are those with other morbid conditions, multi-morbid conditions, where the uptake is rather lower. So we always try and get the vaccination strategy right, and we try and get that messaging early doors, but historically it's always been a little bit lower in Brighton and Hove. Interestingly, if you actually compare Brighton and Hove to its comparators in other cities, so we have our sort of peer comparators, if you like, such as Bristol and Portsmouth, which have a similar demographic population and are similarly sort of student towns, university towns as well. We compare pretty favourably, but that's not really the point, is it? It's, we want to get that number as high as possible. But what we're really trying to do is get aligned plans from our providers this year to improve that uptake, and it's going to be focused very much on the flu uptake rather than COVID, because of the reasons I've explained and you've taken on board before.
The second question was on the no criteria to reside issues. I wondered, Steve, if I could bring you in on that. That's right.
Yeah, thanks, Nikki. Thanks, Chair. I think as both Nikki and Tanya have talked about, the health and care system in Brighton and Hove is particularly complex, and the story about no criteria to reside or people delayed is a complex one. We know that about a third of the patients who use County Hospital are from Brighton and Hove, just over a third. The other 2/3 come from both East and West Sussex. From East, in that sort of coastal strip from sort of Saltdean to Newhaven, and in West out towards Shoreham, Lancing and so on. So it's a complex picture, and I think Brighton is unique in Sussex in that it's in the middle and takes a broad range of patients. I think as well, it was quite a challenging season. It was a high flu season, and the system, I think, coped generally quite well with those demands over winter. In terms of hard numbers and the numbers of delays that were down to sort of adult social care in the city, in Brighton and Hove, by the end of February, we had about 13 people delayed in hospital at the county hospital. And by the end of March, by the 28th of March, kind of the official end of winter, that had reduced down to 11. So our delays for City Council for adult social care tend to stay in the sort of low teens, and that kind of performance was maintained throughout the winter. I think in terms of the future and in terms of what next, across Sussex, each site, each place is developing a place-based plan around discharge transformation. Ours in Brighton and Hove has been signed off, and we're meeting with the Department of Health and Social Care on the 21st of July to go through that plan. So I think that the debate around delays is a complex one. I think we did relatively well over the winter. Our performance maintained its current level. I think it remains a challenge to improve that significantly because of the complexity of the patients that we serve and also because of the resources in the city. Councillor Hill, you asked another question regarding kind of presentation at A&E, not including people with mental health conditions. And I think in terms of a response to that, we are for 2025-26. So as Tanya said, we're planning our winter planning for 25-26 now. We are planning to extend the work of our admission prevention team. So there's a team that works out of A&E at the county hospital, which is comprised of social care workers, social workers, community nurses and therapists that are employed through the community. Since that team was up and running in July 23, we've diverted over 2,000 patients away from A&E. And of course, one of the key elements of delivering good performance over winter or any season and preventing NCTRs is to try and divert people away from coming in the first place. So we do have some additional funds this year as part of the Better Care Fund, and as part of our planning, we're extending the work of the admission prevention team from Monday to Friday to 7 days a week, which we think, again, will have a significant impact on improving the diversion rate away from A&E, and in turn, that will then, of course, improve wait times at A&E and so on and so forth. So we've got a local plan. Each place across Sussex has a site-based plan. As I said, we'll be sharing that with National on the 21st of July. And we're starting our winter planning this year, I think slightly earlier than we did last year, to ensure that we've got as many of those measures in place as we can.
Thank you, Steve. Nikki, do you have any response to come back?
Yes, if we pick up the mental health, I'll pass that to John, if that's okay, to answer that one.
Good afternoon. John Child, Chief Operating Officer for Sussex Partnership Trust. Councillor Hill, you asked a question around, I think, initiatives to support mental health services over winter.
Yeah, so well, it's I mean, it's about the people coming with non-emergency mental health issues and presenting when it's not necessarily the appropriate place. That was sort of the thrust of the question, is trying to understand what's being done around that, essentially.
No problem. So I'll cover some of the winter bit and then some of that as well. Within mental health services, so we don't experience the same levels of seasonal demand that our acute trust colleagues do, but there is obviously a knock-on effect for that, and we would want to support our acute trust colleagues at all times. So I think in the Sussex system, the management of mental health services through the services or through the system that Nikki runs are front and centre. So mental health is very much part of a whole system approach. When you look at all the A&E departments across Sussex, I think this is probably what you're alluding to, Councillor Hill, the patients with mental health presentations, there's a far greater number of those attend at the county hospital than in the comparator A&E departments, and I think that's really a reflection on the demographic of Brighton and Hove, as Dr. Hodgson was talking about in terms of vaccinations. We did have a specific winter plan for mental health services, which included increasing bedded capacity, focus on patients who are clinically ready for discharge in the way that Steve was describing, but specific services to support people to access mental health services not via emergency departments. So we launched in November what's called the Rapid Response Service. So that is a service we work with CCAM and Sussex Police. We led by mental health nurses across Sussex who convene on the scene of emergencies with the blue light services by way of preventing those services to conveying people to emergency departments. And we rolled out an NHS England initiative for what's called mental health vehicles. So mental health ambulances, which are staffed by psychiatric nurses. Working with NHS Sussex, we have enhanced what's called our Staying Well services. So those are our crisis cafe services. Within Brighton and Hove, there's a crisis cafe which is run by Southdown Housing Association with clinical input from us, which is based in Preston Park. And we've gradually seen an increase in activity into that service, again, ideally to avoid emergency departments. And the final initiative that we put in place that hopefully would have been impactful was related to the unscheduled care hubs. The unscheduled care hubs that were in Polegate and Brighton, we ensured that there was a direct clinical link between those services and the rapid response, the mental health services. So when patients were called in or professionals called in with a mental health presentation, instead of dispatching ambulances or other colleagues, they could be directly directed to mental health services. I think it's fair to say that patients presenting in the A&E department at the county hospital with mental health presentations continues to be a challenge for the city and for all of our health and social care services, but there are a number of initiatives in place to seeking to improve the situation.
Thank you for that. Mo from the Older People's Council.
Thank you very much, Chair. Have I pressed the right button here?
Yes.
Sorry, I seem to be lit up twice. Right. I want to just roll back to some of the earlier points. The word frailty came in your presentation. Now, it's no secret that as we all get older, we get frailer. And I think I'd just like a bit more expansion on the work that you're doing with frailty clinics and falls and what have you, you know, the actual work. But I suppose my question is a little bit about more the actual pressures that exist more in winter, because this is a winter service plan. So, you know, is that, do you notice an increase amongst older people falling over or tumbling or whatever we're doing in these frail circumstances in the winter? The other point I wanted to raise, which was something you didn't say, we know that we are all going digital. And in fact, you've all been digitized, hopefully, your records. Mind you, that bears with it. I would suggest you check that when you next attend hospital, because half the time, half the information hasn't been concluded. But we do know that this is quite challenging for many older people, because they might have sensory deprivation like myself, or they just might not be very, au fait with digitization. So I just wanted to really ask you to confirm and reassure and explore with me the backup sort of systems that you've got, as it were. Whatever they are, whether an older person wants to contact a frailty clinic or whatever it is, to actually support those who aren't able to digitise in quite the way that the Secretary of State would like them to. Thank you very much. I hope that makes some sense to you.
Thank you, and it does make perfect sense. Thank you for the question. So to answer the first question around frailty, so frailty, yes, is very much in terms of age related, but it's also related to multiple compound needs, multiple conditions that obviously impact a person's ability to not just care for themselves, but they're more at risk of falls, more at risk of injuries, etc., and potentially more at risk of exacerbation of different conditions. Now, in terms of frailty provision in the community, so what we're trying to do is to ensure we've got that provision in the community and not waiting for somebody to end up in hospital, because it's usually the wrong place for that individual. So we have frailty proactive care hubs that will be sort of set up this winter. Last winter, we had test of change pilots, so there were only small pilots. In the west of Brighton, we had a very small pilot focusing on those that are moderately frail, and there is an assessment that's carried out with various tools. This last winter, we used a Rockwood tool, which pretty much gauges a person's ability to, one, provide their own care, potentially risk of fall because of mobility challenges and or mental health challenges and or care challenges. And what we identified was a more social-based approach to that. So we looked at social prescribing through our voluntary community services, because we also know our VCSE sector partners know their communities much better than many of our statutory organisations, and they can reach into those communities. And Mo, as you mentioned, in terms of digital inclusion, that was one of the actions. So those who could not access the online hub or the online advice were able to go in and speak to somebody directly. In the east of the patch, what we had was a health hub. So it's a drop-in health hub in the east Brighton run out of the Robert Lodge community area. And part of that drop-in is that you don't have to make an appointment. You can turn up on a Friday, anytime between 10 and 1 p.m. So again, for those who may or may not find themselves able to access via the apps, the NHS app, for example, or any other digital tools, they can just show up on a Friday. The advice there is multifocal, so it is from physio to OT to mental health to benefits to information about vaccine uptake, screening, even simple things like carer, food, how do you get your food supply, what support you might need around equipment. So it's multifactorial. It's not just statutory organizations who are in there, it's the voluntary sector who are in there. And mostly, or GP practice, PCNs, we have the health advisors, we have social prescribers who are in there. So again, that does enable anybody to be able to turn up and get support. And most people who turn up, they've had 640 people turn up over the winter months. And what they found was they needed 2 or 3 services, not just one. Initially, they came in presenting with a shoulder pain, but it was a myriad of other issues that would have led to potentially an exacerbation of their condition, potentially a sort of attendance to A&E or GP contact. So those are some of the things we're doing. In terms of wider scale pieces of work, we have a digital inclusion framework, which again recognizes that we need to ensure all of our trust, all of our providers obviously have a digital platform, but alongside that, we'll have a face-to-face, non-digital contact method, which supports those who we know in our communities are digitally excluded, not just because they don't have the hardware, but sometimes because the systems can seem quite complex and or their language barriers. So there are various options. And this winter, we're hoping, as I said, those frailty, MDT, multidisciplinary teams will be ramped up and will be much more comprehensive than the pilots we had last year.
Thank you, Tanya. Mo, do you have any follow-up questions?
Sorry, whispering to Jeffrey here. What were you saying? Though it's excellent, and I know about the Robert Lodge initiative because it's quite close. But as Jeffrey said jokingly, but I mean, there's a serious point underneath it. As long as you're not too frail to get to Robert Lodge. So, if you are a very frail older person, and you are, and I hate this word, but I don't know what else to use, digitally excluded, then you are a little bit. I was going to say something very rude, so I can't say that, but a little bit challenged, shall we say? And I mean, you can't solve everything all the time, but you know, that is a challenge if you can't actually access a direct service. So and you actually are too frail to do that. But anyway, but thank you for everything you're doing.
Thank you, Councillor Zaduzhan.
Thank you. I want to ask you 2 questions. How many additional hospital or community care beds are being commissioned for this winter? And my second question is, are there any plan placed to support a staff shortage and prevent burnout in the NHS and care sector? Thank you.
I'm not in the position to be able to answer the first one about how many extra beds will be commissioned for this winter at this point. So I can't answer that, but as soon as we have any clarity, I can certainly bring it back. When it comes back to staff burnout, there's nobody here from the trust, I don't think, which is unfortunate, but there is a lot of work within trusts looking at staff well-being, making sure that they're supported, that they have that HR, that human resources focus around exactly that, to make sure that they're not burnt out, that they're not going for long periods without holidays, that they have that support around. And there are each of the trusts has specific initiatives. Again, I can't touch on what each of the trusts are doing, but we can certainly bring that back if that would be of interest. Because it's a very, very valid point, especially as we hit winters, which are really, really challenging on staff and very, very demanding. It would be a very valid thing to bring back, Councillor, if that would be helpful.
Steve, would you like to comment?
Yeah, thank you, Chair. Yeah, just in terms of your question, Councillor, on additional beds, I think as a system, we're trying not to commission lots of additional beds this winter, and we're trying to take an approach where we support people to go home much more often. So we have increased the number of reablement beds at Creighton Vale Resource Centre by a couple this winter. And we are also looking to increase some of our step-down beds in another one of our establishments. But we know that around 50% of people that go into those short-term beds end up staying there long-term because they become deconditioned. And so the approach we're really attempting to make this winter is to put our resources into getting people home with the right support as quickly as possible, rather than take a bed-based approach.
Thank you. Do we have any questions? Councillor Smith.
Thank you, Chair. Apologies if this is it's not the best question. I'm trying, but new person here, so it's all a bit jargonistic for me at the moment. So I'm trying to looking at this report. I'm looking at this effectiveness score, which is 6.26 out of a possible 10, and I'm wondering how that's arrived at, because it seems to be quite a simple digital response to what is obviously a set of very complex questions. So I'm wondering how that's kind of boiled down to those numbers. And then I'm also, you've included some suggestions, but I would be interested to know what of those suggestions are sort of genuine, concrete ways forward. That's my question. Thank you.
If I take the second part first, do you mean what our objectives are around the areas for improvement and what we're practically going to do about those? Thank you. So we have measures in place for a number of those for all of those areas for improvement. So I'm coming back for the performance. So some of those are much simpler around around discharge figures, around the long length of stay. We gather those on an ongoing basis, on a daily basis, and have all of those figures. They're very simple for us through the processes that we have into our Opal and our Shrewd. So we can be looking at those on an ongoing basis and actually seeing how any of the changes that we're putting in start to impact on those outcomes. The other piece is around the respiratory diseases and impact for the modelling. Again, we keep modelling on who's coming in and with what that they're presenting with, and any actions that we bring in, we can actually see the sun directly in my eye there. See the impact around there. So all of these things have measures that we put in place to make sure that we're testing everything that we bring in to see what the outcome is. If you can't measure it, then there's little point doing it. You need to be able to measure it. On the first point, I'm not sure that I can answer that at this point. Can I come back to that with you with some more information on that? I think it's a little too complicated for me to try and understand, but I can bring back the answer to that. Thank you, Councillor.
Thank you, Nikki. Do any of the members have any questions they'd like to ask? Don't see any indications. So I will now ask members if they're happy to note this report. Thank you very much. And thank you, everybody, for coming along to present today. We now move on to the second agenda item, which is children and young people's mental health services. And we are joined today by members of the Sussex Partnership NHS Foundation Trust, John Child. And John, if you would like to present your co-presenters.
Thank you very much, Chair. And thank you for having us here today to give you an update on children and young people's mental health services. The report covers a couple of things. So we look specifically at the provision of children and young people's mental health services around Brighton and Hove, and then touch on the transformation programmes that are in place, both around mental health services, but also around neurodevelopmental services as well, which we know is a particular challenge at the moment. If we just do a quick overview in terms of the key services that are in place from a Brighton and Hove perspective. So when we look at mental health services, the key services are really around the school's mental health service, the wellbeing service, and then the specialist CAMS services. From a school's mental health service perspective, There is that really caters to the mild to moderate end of acuity that we see within children and young people. It covers a broad range of preventative psychosocial and psychotherapeutics interventions, and importantly integrates with the school's mental health the mental health support teams, which covers 65% of the schools within Brighton and Hove. When we look at the wellbeing service, again, the wellbeing service caters to the mild to moderate end of presentation, specifically around anxiety and depression. And that's an integrated service delivered by SPFT, but also with YMCA Downs Link Group. In those children where we see a more acute presentation, we have the specialist community children and adolescent mental health services, so the CAMS services. That's for the moderate to severe end of presentations, and that covers a range of specialist teams covering eating disorders, early onset psychosis, and a range of others. We've listed out the various different services that are provided, and those provided by SPFT, who I'll pass over to you shortly to provide a bit more detail. In terms of the service activity and waiting times, which I know will be of particular interest to people, when we look at the school's mental health service, I think we've drawn out in the report that over the past year, there were over 6,600 direct contacts with children, young people and their families. So it really does provide an integral early intervention type service. And we've also drawn out in there that of the 1,244 children and young people triaged, only 19 required an escalation through to CAMS services. So sort of really provides an overview of the importance of that early intervention type service. When we look at the children and young people's wellbeing services, again, we can see in there that while waiting times historically have been longer than we would have wanted, we have seen a significant improvement over the past year, moving from 20 weeks in September 2024 down to 8 weeks by May 2025. And also the numbers waiting for treatment have come down significantly, falling from 197 down to 55. And then again, when we look at the specialist community CAMS end of things, again, we can see that while referrals have increased, the number that are currently on the caseload and awaiting assessment, although the number remains high, we can see that the waiting list size has started to come down. CAMS neurodevelopmental services. So we know this is a particular pressure. It's a particular pressure across the whole country, similar to the pressures that we see, I guess, more widely around mental health services. But neurodevelopmental services and the referrals and the number of referrals that have gone into those services in recent years have really increased dramatically. And we know that that is a problem, and we go on to talk about some of the transformation work that's in place, but that does mean that currently we have a significant number of children waiting for assessment, and the waiting time for assessment is significant and much longer than we would want it to be. The earliest data that we've got in there is around 2022, but you can see that the waiting list remains high. We recognise that there is a significant impact around waiting times, and that does create a real challenge both for the children themselves, but also families and carers. So we've tried to draw out in the report some of the action being taken to try and support individuals while they are waiting and while that transformation in work is undertaken. And that also we touch on the supporting the transitions through to adult services as well, because we know that children that present in mental health services often then do run through into adult services in that transition, and the management of that transition is really important. We touch in the report around drawing on the experience of children and their families who use our services, and that is absolutely key in terms of shaping the transformation programme and the key areas of focus going forward, because it's really important that we understand the experiences of people using the services and that we respond to those in terms of how we transform services and how we adapt services to better meet the needs of people. And we do have a strong programme of engagement with children and young people in helping to shape those services. And then we touch on some of the transformation work that's currently in train. So from a mental health transformation perspective, we've drawn out in there are 3 real priority areas of focus as we move forward. So a big focus on getting advice and help. So trying to make sure that there is that early intervention and support across a range of services. We also touch on the urgent emergency care services, which we know Again, that kind of early intervention when someone is in crisis and how crucial that is. And then the specialist community CAMS development. And then we go on to look at the work that's being undertaken as well across the neurodevelopmental pathways, and looking again at how we get into tackling those long waits and looking at how we deliver those services differently going forward. There's a huge amount of information in the report. I'll just pass over to John though to see if there's anything in particular you wanted to draw out around SPFT. Sorry.
Thank you, Claudia. There's not a great deal more to draw out, Chair. I think probably from a Sussex Partnership perspective, it may be worth moving to members' questions, because I anticipate there will be some and we'll probably be able to get into the detail.
Thank you, appreciate that. At that point, I'd like to invite the members to ask any questions. Councillor Evans.
Thank you, Chair, and thanks for the report. I'm sure there's lots of information in there that I haven't quite taken in because we got it a bit late. But I wanted to ask about waiting times, and because there's obviously significant concern about waiting times for all young people, but perhaps more so about extended waiting times that have apparently been experienced by children in care when accessing appropriate mental health support. I have direct personal knowledge, albeit from a very long time ago, as you can see, of how traumatising the experience of being in care can be on its own, without even going into the many equally or more traumatising experiences that led children to be in care in the first place. So it currently appears anyway that the health service doesn't systematically collect or consolidate performance data specifically related to mental health support for this vulnerable group of children. But surely establishing a dedicated data set to track service delivery and outcomes for them would provide valuable insight. It could highlight gaps and delays in care and strengthen the case for prioritising children in care within the system. And potentially, I mean, you were talking in your presentation about prevention being so important, of future problems. It could potentially head off more long-term issues and problems that can blight lives far into the future, and catch them before they become more difficult and intractable to treat. So, I mean, maybe some of this is collected separately and I've missed it, but can you confirm whether you do currently collect and consolidate data on wait times and access to this support specifically for children in care? And if not, are there plans to develop such a data set to better monitor performance and help ensure that children in care are prioritised? Thank you.
Thank you very much for the question. I'll start. So I think you asked a question on, do we capture data of children and young people who are looked after by the local authority systematically? No, we don't. So we don't, I couldn't, if you said to me today, how many children are within your secondary mental health care services who are looked after by the local authority, that's not something we would be able to answer at the press of a button. Do we take into account young people's backgrounds, clinical presentation when they're referred to our services? Yes, absolutely, of course. And we would clinically prioritise them for interventions, assessment and treatment accordingly. And by virtue of the fact that they are looked after, they may have experienced higher levels of they may have higher level of needs than perhaps other young people, and that would, of course, be taken into account. Is it an area, I think what I've heard you say is that that's an area you think that we should develop particularly in terms of the data recording and how we might capture that data systematically. We're just in the process at the minute within the trust of procuring a new electronic patient record. So that's certainly something that we can take away and talk to our colleagues about and say, actually, I wonder if there's an opportunity for us to be able to do that.
Yes, thank you, because I do think that cared for children are probably statistically, I mean, no statistics, so who knows, but I would say probably statistically exponentially more likely to have quite
severe mental health crises, and therefore there is an argument, if you've got the data to back that up, there's an argument for prioritising them within the system. Thank you.
Jeffrey, a question from Health Watch?
I was just going to ask a simple question. I mean, great that waiting times have come down, but I'm just wondering whether you actually have the capacity to deal with the new people coming down the track. And known a personal experience from a friend of mine who has taken 5 years to get any support for her son, who is not in school and being home educated, and she's had to give up work. So there's a lot of impact on delays, not just on the young person, it's the family, the carers, and so on. Do you have enough people to do the work?
So I think capacity will always be a challenge. What we're constantly looking at doing is where the opportunities are to deliver services differently and more efficiently. Workforce is a finite resource and develops and depends also on training programs in place and making sure you have the right pipeline of staff coming through to be able to resource services efficiently and effectively. So I think there's two things that we look at doing going forwards, which is what will the future requirements be, and how do we make sure that we have the appropriate workforce development plans in place. I think Sussex Partnership in particular have been doing some great work around joining up with higher education and others to sort of look at how you encourage more staff and build that workforce. But there's also looking at how you deliver services differently. So how do you start to better triage and segment those who come through from referral and look at those who could be managed through potentially digital support options versus those who really truly do need face-to-face type interventions, so that you can start to segment and use the capacity that you have as effectively as possible. But yes, capacity is a challenge, and particularly when we see the rate at which demand has risen in recent years. So your ability to expand your capacity at the same rate at which demand is rising, I think has been a real challenge, particularly post-COVID.
Thank you. Councillor Cattell.
Thank you, Chair. I'd just like to follow on from what my colleague Amanda said about children in care and care leavers. I recently took over chairing the corporate parenting board, and at the very first meeting that I chaired a few weeks ago, there was a specific item on children's mental health. And one of the things that a group of care leavers had put together was their own presentation with information that gathered from talking to each other. And one of the things that came up was that there is an additional layer of trauma for them. And also we, as a council, consider looked after children as a sort of specific protected characteristic. So, and we did discuss the fact that there was no capture, as Amanda said, of the data. So I'm hoping that you can progress with that. The other thing that I was going to say was about SEND and SENCOs. Was yesterday I was in another scrutiny committee yesterday where we had a big discussion about SEND provision in schools. And obviously there's going to be a crossover with your services that you provide. And I wonder how that interface works, and do you have regular kind of meetings with SENCOs and go into the schools to sort of see how how well the service is doing with in relation to those particular children? Thank you, if that makes sense.
So we work very closely with local authority colleagues around the SEND agenda. So there is a big programme of improvement work that feeds off the back of the review of SEND services that was done. And we've had all three places have gone through their SEND inspections, and each one has a detailed list of recommendations which come off the back of it. So yes, so there is a comprehensive programme of work that looks at how we better join up services and make sure that we've got more responsive provision. Again, I think waiting times was a consistent theme that came through that, and I think that touches on the waiting times point that we make in the report, particularly around the neurodevelopmental services.
Sorry, if I could just add to that. So I'm Emma Sharp, I'm the acting service lead for the school's mental health service, and we regularly link in with all of the SENCOs. So although we are not directly under SPFT in the NHS, we are linked in with those colleagues, and we offer weekly advice drop-in sessions for our SENCOs in the city. So they are welcome to attend those, and we can signpost to the appropriate support to make sure that early access is available. And we link in with CAMS to follow up on any referral needed as well.
Nora.
Very much for your presentation. I've got a few questions. Is that okay? Yeah. So when we're talking about referrals received, are we talking about the referrals that have been accepted, or all referrals, including those that maybe initially being rejected, or maybe after assessment being rejected? Also, have you got any data on the referrals for the eating disorders services? Because we got some feedback from GPs that it seems that many of the referrals are being rejected. It will also be interesting to find out about the rejected numbers. What happens with those? Are they then being signposted to other services? I'm thinking, as I'm a representative of the community voluntary sector, and you know, we have lots of great organizations doing some really good work with the young people, thinking that Black and minority ethnic young people's project. You think about Hamilton and Knoll project, think about Amaze, who, you know, also support a lot of the young people. And when you were talking about preventative work, I mean, they are a great space where they offer the support, and potentially through a bit of like social prescribing for young people. I think the YMCA does that a little bit, if I'm not mistaken. So, and is there scope for more? Is that going to be developed more? Because there's a lot of holding that's going on. And also, if young people have been referred and they get rejection, often at those clubs, whatever club it is, the activities that they attend, they get that support from the staff there. There's a lot of like coaching going on. There's a lot of, you know, building up confidence in those young people. So yeah, so my question is, would that be something that you're gonna develop further as well? Oh yeah.
Thank you. Thank you very much. I will answer your first two parts of the question and then pass over to colleagues. So the data in the report is referrals accepted, not referrals received. So I think, I assume your question is, where do the referrals that are received that are not accepted go? And what's the feedback to referrers and to young people and their families? So all of our referrals are triaged clinically, and they will be seen by clinicians, and a discussion and decision will be made as to the most appropriate treatment or assessment pathway. And yes, we do give advice to GPs. That may be advice around, actually, we think this young person would be better suited with the wellbeing service or with a community and voluntary sector organisation or in a mental health and schools team, or it may just be treatment advice around medication or similar. So often advice and guidance may be offered. It may not be that the referral is actually formally accepted and then they're brought into assessment and treatment. You asked a question about eating disorders and eating disorders data. So I'm just looking through, actually, it's not in there, is it, the referral data for eating disorders? There are two national metrics that we are measured on in terms of referrals. So one's for urgent and one's for routine. The urgent is that we have to see everybody within 7 days, I think colleagues will, yeah. And the other is within a calendar month. And broadly, as a system, a Sussex system, but both in Brighton and Hove, we broadly meet those criteria. And the number of young people that aren't seen within 7 days for an urgent eating disorder is very much single figures on a monthly basis across Sussex. We very closely monitor that activity and closely monitor the decisions that are made because of the comorbidities of that patient group and the particular risks that sit with them. But if you were interested in the data as to referrals received and referrals accepted, that's certainly an action that we can take away and come back to you. Does that? Yeah. I'll pass over to Lizzie.
Hi, I'm with Lizzie Izzard, Head of Children and Young People's Mental Health Commissioning for the ICB, and I just wanted to come back on your important comment question around how we ensure that organisations and support services across the city is everybody's engaged and can support children, young people and families. And you'll see from the paper that we talked about our key transformation priorities, the first one being around getting advice and help. And what we really recognise and we've heard from children, young people and families is that it can be really confusing to navigate the support that's available to them, and they don't always know where to go. So a key element of that work within getting advice and help is being really clear about consistent and clear communications and signposting for young people and families. And we're doing that in partnership with organisations across Brighton, Hove and Sussex. So, you mentioned, for example, Amaze, which provide a fantastic service for children, young people and families, and they're engaged in conversations along with YMCA, local authority colleagues, so we can really ensure that we can properly describe and signpost and help children, young people and families get to the right place first time. So the key element is around communication, and the second area of work that we're doing is around access. So again, being really clear about those access points so that it isn't about a referral being rejected. It's about being really clear that that young person gets the right service first time.
I used to think I've been here so many times that I know how the thing works. Do you include kind of looking at a more demedicalised? Okay.
Yes, really important point, because I think what we see all of the time is there is often a need for medicalising how a young person is feeling, and actually what we do know is that they need often a different type of support. So you referred to social prescribing. So for example, we're working with colleagues across Sussex to ensure that those social prescribing offers are in place, and it's about, like you mentioned, about how we signpost and ensure young people can access those community groups and clubs that can support them with their emotional well-being and mental health.
John, would you like to come in?
Thank you. I was just going to bring in my colleague, actually, one of our lead clinicians, to talk around particularly around the actions that we take when young people are waiting for intervention, because I think that's the other part of the story. It's not just the data per se. It's actually, so what is the people's experience when they're on the waiting list? So I'll pass over to Anna.
Thank you. My name's Anna Moriarty. I'm a consultant clinical psychologist and the Associate Clinical Director for CAMS in SPFT. So we do recognise how difficult it is for young people and families when they're waiting extended periods, and sometimes that can be uncertain as well, as because we're a needs-led service. Sometimes we're not able to say exactly how long the wait is going to be when we're prioritising young people, and we've been doing a lot of work around this and really listening to young people and families in terms of their experience as well. So we've had some really helpful feedback which has helped to shape our offer around waiting. We were calling it Waiting Well, and actually we had some feedback that actually Waiting Well wasn't a very helpful way of describing it, because they weren't feeling well, and actually it was about support or CAMS readiness. So we're trying to shift our language around that to be responsive. So some of the things that we've been doing is really kind of refining our list around availability of resources, all of the things that Lizzie was talking about that we're working within this Thrive framework, so we know exactly where the good quality advice can be signposted to. And while waiting, really monitoring how young people are doing. So we've been using letters to do that. You might have heard them described as kit letters. We've also had some feedback that the kit keeping in touch letters, they're not so helpful. So we've done some work to co-produce those, and particularly within our neurodevelopmental path, where we've now got to while you're waiting and when to take action leaflets, which young people have helped to develop. And we're just piloting in Brighton, actually following a pilot in East Sussex,
a programme where we're actually phoning every young person to get an update where we haven't heard from them or had contact with them within the last 3 months. It's really important that we not only send something written out and let them know that we know they're waiting, but also that we make contact and we review their risk assessment and care plan. So that's very much part of our transformation work. And then obviously just really important to mention that young people and parents and carers are advised of our duty system. So we have a duty and liaison system which is available to all young people while they're waiting. So that's a very active part of our service and responsive within the same day if young people and families contact and their difficulties have increased and they need more urgent support.
Councillor Simon.
I've got a couple of questions. One which you kind of partially answered actually. So I might give you that one first. And that was about young people and children being involved, which it sounds like they are to some degree. So that's fantastic to hear in the sort of planning and evaluation of the service. And I asked that particularly because at the last sort of corporate parenting board, in fact, at all of them that I have been able to attend, the young people there are so insightful and they really do have so much to share and to give to help services to respond to them in particular. So I kind of feel like most young people would probably also be equally insightful. So that's my first question is, how, apart from those ways that you've already mentioned, which are appreciated, are there any other ways that you're involving young people in planning and evaluating and developing the service? That's question number one. My second question is about transition planning. I've got a personal experience of trying to get a young person mental health support and being told by my GP that they fell between adolescent and adult services and therefore there was nothing for them. I now know that not to be true, thanks to the fantastic Health Watch who took that on for me and educated my GP. But I'm particularly interested in that and how you manage that continuity of care for young people between adolescent and adult services when they're kind of on that, at that age. Thank you.
Just from a service planning perspective, I guess, in terms of that engagement with children and young people, there is a really active programme of engagement, and we've got children's ambassadors who we regularly engage with and draw on to gain their experience. There was a significant event held in March as well, which drew in a wide range of children and young people to hear their voices, and we're using that very actively to inform the development of our services going forward. And in fact, I think we've got a paper going to the ICB board in July, again, which really draws on the input from children and young people, and that is very much about making sure that those views are taken into account when we're commissioning services and we're thinking about how they need to be developed going forward. So I think we really do value the inputs of those children, as you say, hugely insightful, and very grateful for the fact that they give up their time very willingly to contribute to the development of services.
It's okay to come in there. So just to add from a Sussex Partnership perspective within CAMS, we've got quite a long-standing programme of work around engagement with young people, which is absolutely fantastic and has meant that as we've embarked on our transformation programme, we've already had a group of really engaged young people who've been working with us. So we've been running a number of engagement events which young people have attended and given lots of feedback. We've had events with parents and carers which have been less well attended, but actually we launched a survey a couple of weeks ago, we had a kind of overwhelming number of responses within about a week. I think it was over 250 responses within a week from parents and carers. So we're thinking about the different ways that we can hear the voices of service users. But we have young people involved in all parts of our service delivery. So on recruitment panels, for example, we've recently launched our new crisis and intensive home treatment service within Sussex Partnership. And young people co-designed that. So they were talking on BBC Radio Sussex last month. I don't know if anyone heard that, but it was absolutely inspiring to hear them describing the service that they'd helped to co-design and the resources and all of the ideas that they brought to that. So really trying to
co-produce rather than consult with young people, which is always it's a challenge, isn't it, to do that at the pace that we work, with the pressures that we experience in terms of the numbers of young people needing to access the service. But we're very much continuing to try to do that. And I was at the corporate parenting board where the young people presented, and it was fantastic. We've made contact afterwards and hoping to link them in to our participation programme.
You asked a question about transitions, and I can start, and then perhaps colleagues will come in. So I think it's probably fair to say that it's been an area of challenge for us, and not least because many of the young people that we are growing into adulthood don't just receive care from mental health services, they receive care from other services as well. So the same transition experience between children's social care and adult social care just can add additional complexity. It's one of our, certainly it's one of our key areas and objectives within our CAM services to seek to improve. And I know that the paper describes briefly some of the actions that we're taking. There are some clear expectations that we have within our services around when a young person reaches a certain age, that then they are referred to our adult services if they need ongoing care. Then there is a detailed process of transition and clinical handover and working with the person themselves and of course their families. And we have a transfer of care lead in place. There is a capacity challenge, going back to the question earlier around demand capacity that was asked by Healthwatch that Claudia answered, particularly around the neurodevelopmental services. So children and young people who may be receiving treatment, so pharmacological treatment for perhaps ADHD, and then transferring them into our adult services, it is a challenge. It's something that we're working through. We're working through it with our adult neurodevelopmental services and with our commissioners and primary care colleagues as well. So I think in summary, area of long-standing, area of challenge, something we're very live to, and there's a few specific actions in place. Okay.
Yeah, that's great.
Thank you. I think it's Steve would like to come in.
Thank you, Chair. Just in addition to the information my colleagues have given, at the Mental Health Oversight Board for the City yesterday, which tends to have a focus around adult mental health services, we did approve a kind of a transition strategy around mental health. And we are intending to hold a workshop in the early autumn, specifically around the transition of young people with mental health needs into adulthood. And as John's indicated, a number of those younger people don't always go to transition into adult mental health services, but a range of other services. So I think as a system, we really recognise this as an issue, and we really recognise this issue as a key issue in the city. So there is some specific work going on in the next few months around transitions.
Thank you. Councillor Parrott.
A couple of questions. I wanted to ask about support for parents, particularly when young people are in crisis. So, there's something around how triggering and traumatizing that is for parents. For context, I'm a psychotherapist and I work quite a lot with eating disorders. So I see the parents often of children who've gone into crisis with eating disorders. It's extremely difficult for them to deal with. And, I'm aware that in Hove, where I live and where I work primarily, there is a feeling that there's very little support for those parents. They don't really know how to cope and how to manage, and they feel quite often very shamed and blamed for what's going on with their children. So that's one question. The other question I wanted to ask actually about eating disorders, particularly with children, particularly with younger children, is whether where the preventative work is doing. We're seeing more and more young people coming through 7, 8, 9 and 10 with the beginnings of what one might look at and say, this is problematic. Children being very restrictive around their dieting and their eating, hiding food, etc. But also in that eating disorders spectrum, I wondered about obesity, because obesity is obviously a huge problem that we face, and it isn't just a physical health problem, it's a mental health problem. And it does lead to can lead to long-term mental health conditions going down the line. There's a lot of data showing that obesity is very correlated with depression, childhood sexual abuse. So, there's other things that are going on underneath that, and just was very curious about, where you're at with that, and are you beginning to look at that and what work is being done?
Thank you. So I'll just come in around the support to parents. So a really good question. Really important aspect of our work in specialist CAMS is working with parents and carers. and families, and also thinking about the impact on siblings and the wider system. So our teams are multidisciplinary. So we have, a range of professionals, including psychotherapists, systemic psychotherapists, who really take on a lot of this work and consultation, as you'll know all about that. Yeah. And that's just a really important part of the work. So we're redesigning the CAM service currently with everything in mind that we've talked about and the challenges, but a really important aspect of that is it being evidence-based. And we know there is a really strong evidence base for having a systemic offer and to be able to work with the whole family, not just directly with the child. So that very much will be part of our offer moving forward. In terms of our launch of the COAST service, the crisis service that I mentioned earlier, that's been co-produced with young people, part of the sort of, I suppose, the vision behind that is that it's really about supporting families to feel empowered to manage that crisis at home. And while that can lead to uncertainty and anxiety, that actually the team it's a big team that's launched, multi-professional, which will be really working with families closely at home to think about how do they support them overnight, how do they manage between the visits, and how do they feel able to continue with accessing the community and school and everything that a young person needs and not have to go into hospital. So that's really sort of central to that model, is working with the whole family.
Sorry, just thinking as well there about the transition. So when people, to come back to Councillor Simon's point about transition, when they're transitioning, often then that's the point at which families and parents particularly can feel quite excluded from what's going on, because whilst they may technically come under adult services, obviously we're seeing, you're seeing significant developmental delay with children who might have been in service and in, under CAMS or someone. So you're seeing significant developmental delays, and yet they're being, transitioned out into adult services. And their parents and maybe their other members of the family don't feel that they're actually ready to do that. And I recognise the dependencies around all of that, but there are obviously concerns as well around that transition period.
I would agree, and I think it's important for us within CAMS to be working with families through that transition. That's very much part of the work that we do. And then for our adult services and SPFT, very much thinking about carers and families, and that's part of their model too, that they, while it's a different approach and you're working with a young adult, that's still very important.
So in terms of parent carer support, I suppose I just wanted to reassure you that through all of the transformation work we're doing, particularly in the getting advice and help space and urgent and emergency care, key feedback has been we need to do a lot more. That the parents and carers are the ones that in the main are with their children, their loved ones 24/7. And it's not just about working directly with the child. And so there's some key work streams within those programmes of work about how we develop the parent carer support offer, which will go from just being able to access advice and support to much more working with parents and carers. And one of the first things we're doing is an audit and really understanding all of the different services that are in place across Sussex at the moment. They've all developed different ways of working with parents and carers. So how do we build on what's working well and really start to develop a really clear and consistent offer and way of working with parents and carers across Sussex?
I was just going to come in on the point you raised around obesity services. Obviously, it's not something that we've considered as part of the report today, but if it would be helpful, there is something that we could bring back to a future meeting around weight management services, and whether it's with a particular view around children, adults, or both. There is certainly something we could bring back to the committee.
Yeah, I'd be very interested to see something like that brought back because of the long-term impact as well. I mean, this is about prevention, and, we've got a clear problem in this country with, rising rates of obesity. And, many professionals working in the service would consider obesity to be an eating disorder in the same way, as maybe some of the other more maybe understood eating disorders. I know how hard it is to work with it. So it's an incredibly difficult thing to work with in the same way as anorexia, for example.
Sorry, I tag with the speakers. I would suggest it's something we bring back as a joined up paper between ourselves and public health, and then we can cover the full spectrum of sort of everything from prevention through to treatment.
Councillor Hill.
Thanks. Could you talk a bit about the new pilot that is mentioned in point 4.6.2 in order to coordinate ADHD and autism assessment pathways? It's about reducing duplication and delays, which seems positive to me. I appreciate it's sort of a separate thing from CAMS, but as it's in the document, I'd be interested to understand more about that and the obviously relationship between the two, just because obviously those long wait lists do have an effect on people's mental health. Yeah, thanks.
Sorry, I'm just trying to find the point you referred to in the paper to make sure. Oh, okay, thank you. So, yeah, so in terms of the neurodevelopmental program, what it's done is try to highlight, well, it has highlighted priority areas, which is really focused on how we address and support children and young people's needs, as opposed to focusing on assessment and diagnosis all the time, because we recognise the significant length of time young people have to wait. And so there is a pilot underway of the Dimensions Needs-Led tool in school, which is about, it's a tool that helps those people working with the young person, the family, to really understand the needs of that young person and put in place to support them. So it's about trying to move away from always that waiting and needing that diagnosis, and being able to be much more responsive to the young person there in place with the professionals, carers that are already working with that young person.
Just so I understand correctly, how does that work in terms of EHCP? Because there's obviously wraparound support, I think, which, I don't know, maybe wraparound is probably not the most accurate phrase, but there is support in theory in relation to an EHCP. So how does this pilot interact with that, if that's possible to ask?
I mean, so it can complement it. It can be something that will help inform the plan if an assessment has taken place and a plan has been developed for that young person. But I think what's really important with this tool is that the ultimate goal is it's available to all children that are presenting with need within school, for example. So we know that only a certain number of children will go through to the education, health needs and assessment process and be given a plan. This is about being really clear, a systematic tool of understanding the needs of that young person and being really clear about how the school, parents and carers might be able to meet those needs.
And I had another question that's on CAMS specifically, and thank you for the answers there. So I'm interested in what is being done to support children experiencing gender-related dysphoria within CAMS, and kind of what kind of mental health support is provided specifically tailored for children with that experience.
Thank you. I'll take that one. So we recognise there's been quite a lot of change in this area in terms of the change in national guidance around working with gender incongruence. So we've been working with NHS Sussex and with the kind of national NHS England with the team in terms of the shifts from the previous GIBS service to the new national team. So we're aware of the kind of updated referral criteria to that service. So there is a specialist service nationally that we can refer into. But actually, we know that we see lots of young people within CAMS who they don't come to us around their gender dysphoria or incongruence, but actually may have gender incongruence as part of their experience. So we very much would be making our services accessible to them in the same way that we would for any other individual difference. So while we don't work specifically in the domain of gender dysphoria, we have obviously been thinking about how we can offer that holistic assessment that NHS England's really talked about following the CAS review. It's really important that we think about the vulnerability and additional needs that a young person may bring, or the safeguarding aspects of that, where a young person does have that gender identity element to their formulation, their understanding of their distress.
And just following on from that, do you feel that staff are properly supported in terms of being able to provide that help and understanding the sort of referral process, as it's obviously been in some amount of flux, as you say? It would be good to hear just, if you could speak on that.
Yeah, so following the CAS review, we've been following the national advice around sort of updating staff skills and competencies in this area. So the recommended training was something called MindEd, which is available online, which has sort of been rolled out and recommended for all professionals actually, so not just within health. So I think education as well is a really useful resource. So all of our staff, or certainly in the process of nearly all of our staff have completed that, going through ensuring that everybody's had access to that. And providing supervision particularly and reflective practice spaces for staff to bring the dilemmas around their practice in relation to gender incongruence when that presents as part of the clinical picture for a young person. So I would say that it will take time, I think, for professionals to adjust to the new ways of working, and that's certainly in process in Sussex.
Thank you. I can't see any further indications from members. So I'm now going to ask committee if it's happy to note the report. Thank you. And I'd just like to thank all the presenters for coming today, giving your time and for answering them questions in some detail. Thank you. I'm now going to move on to the last item on the agenda, which is the update on changes to City Acute Inpatient Dementia bed provision, and invite John to speak again and to share with us any co-presenters. Thank you.
Thank you, Chair. I'm sorry you've had to hear a lot from me this afternoon. I'll ask my colleague to just introduce herself before we kick off with the slides.
Hello everybody, lovely to meet you all. My name's Laura Murphy. I am the Director of Nursing and Quality for Brighton and Hove.
Thank you. Giles, are you going to...
Yeah, I am.
So, Chair, I'm just going to talk through the slides, and then I guess members may well have some questions for Laura and I. Giles, are you happy to adopt the Chris Whitty role? Thank you very much. So members may remember in autumn of last year, myself and a clinical director for East Sussex and our clinical director for specialist older adult services came and presented to yourselves around our plans to change our dementia inpatient provision within the city, within Brighton and Hove at Millview Hospital, which is in Hove. And the plan was to repurpose our dementia ward and reopen it as an adult mental health ward, as you see described on the slides. And that was a direct relation to population need, and particularly going back to our conversation earlier with Councillor Hill around pressure that is experienced within the emergency department at the Royal Sussex County Hospital. That also allowed us to invest within our community dementia services, particularly in East Sussex, which was disproportionately lacking in community provision, but it did allow us to invest a small amount of money within Brighton and Hove and within West Sussex as well. And the presentation today was we were asked by the previous chair of the committee to come back and update on progress, impact on patients, families and carers, impact on staff, and any outcomes and next steps. So that was the purpose of us coming back. Giles? So the progress, so Brunswick Ward. So Brunswick Ward was the name of the acute dementia ward at Millview Hospital, and that closed at the end of October last year. 5 of the patients on the ward were discharged to 24-hour residential or nursing care, and then 3 of the patients were transferred to alternative beds within the trust by the end of October. You may remember that we had secured investment capital money from NHS England to refurbish the ward, which we did, and that reopened in May of this year. We called Palmyra Ward, which is the naming convention that's in keeping with all of our wards at the hospital, where it all reflect local areas within Brighton and Hove, and that brought us an additional 13 adult mental health beds within the city. Tayburn Ward, which is another of our wards, was renamed as Falmer, and we changed that to a mixed gender ward, and we increased the beds by 3. So this brought us additional beds within the city for the population of Brighton and Hove. At the time, members asked us around how had we worked with families, how had we worked with carers, and how had we worked with people who are delivering the services on our wards prior to making the changes. And as you can see described, we delivered a number of sessions for families and carers for people who are currently on the ward, and you can see their feedback on the slides. Some carers said they wanted to be more involved in the decisions. People were worried about travelling. Because our other inpatient services are in East and West Sussex for this patient group, and we kept staff updated throughout the changes in the way that we've mentioned. Thanks, Giles. How did we engage with families and people's carers? So we had regular meetings led by our participation leads. So similarly to the questions asked around our children and adolescent service, we have participation leads who specifically work with families and carers who are not clinicians within the services to advocate for those people. So we work with them to hear their questions and concerns. We obviously wrote to all of the families to explain the changes that we would be making. I know that potential transport concerns was an area of members last time, and that's something that we worked through with people receiving our services in providing information about alternative travel options. Obviously, for the patients that we had to transfer, we had discussions with those around which would be the most appropriate ward for them to transfer to. And as you can see, it describes on admission, patients and families receive information and welcome packs. And we have a dedicated group to improve our communication with our families and carers who use our specialist older adult services across Sussex. Thanks, Giles. There was a question asked by members last time around how are we involving our staff? How are we supporting our staff in these changes? So we obviously had to undertake a formal change management or a formal consultation process with all of our staff, as you would expect us to do so. And we worked with our staff side or our trade union representatives throughout that. All the staff that were working on the ward were redeployed across all of our other clinical services and then were consulted to come back onto the ward. The majority of staff did come back and are now working on the female adult ward, whilst some, of course, have chosen to take up permanent positions elsewhere in the organisation. Thanks, Giles. One of the key areas of what we called our case for change was in strengthening the intensive community support for people in crisis, in a dementia crisis or at risk as hospital admission. The aim, similarly to how Steve described as part of the winter plan, was to support people to stay within their own homes wherever possible. In Brighton and Hove, as a result of the changes that we made, we're recruiting a new role to offer extended support to families and carers for people experiencing increasing distress. That's a direct result of feedback from families and carers. That is a role that they identified that we didn't have. In West and East Sussex, you will see that we're increasing our intensive support practitioners, particularly focused in East Sussex. East Sussex didn't have a dementia crisis service. It didn't have a care home in reach service, both things that Brighton and Hove do have. So to understand the impact of the changes that we made. So the slide there describes the numbers of Brighton patients who were admitted to Brighton East or West Sussex beds between March and the ward closing at the end of September. And you can see the numbers, 9 patients. And then it describes the number of patients who were admitted, Brighton patients who were admitted, and where they were admitted between October and the end of April this year. So as you can see, one patient was admitted to an older adult ward, so not a dementia ward in Brighton, one to East Sussex, and 7 patients to our ward within West Sussex. We have 3 dementia wards in West Sussex in Worthing. And then there's some numbers there around the length of stay. So before the changes, the length of stay was, average length of stay was 91 days, and that's reduced to 77. Admissions data. So in the 7 months before the ward was closed, the average wait for a dementia bed from the point of then a patient being clinically assessed as needing to come into hospital was just under 3 days. During the winter time, again, goes back to the first presentation this afternoon, a small number of patients in West Sussex experienced longer waits. And then from January to March, the average wait rose slightly to 3 days. Just to provide the context to anticipating a question as to why are people waiting for a period of time to come into hospital, and what are you doing about that? And this talks to the conversation that we were having in the winter plan, particularly with the focus on discharge. 50% of all of our beds who care for people with acute dementia needs are occupied by people who we classify as clinically ready for discharge. So people who are waiting to leave hospital to receive inpatient, to receive community care or social care. And then we've broken that down by the average length of each delay. We've broken that down by local authority. So you can see in Brighton and Hove that the average length of delay is currently 20 days, and in West and East Sussex in excess of 40 days. And on the whole, all of those patients are waiting for ongoing residential nursing and domiciliary care. And the challenges are the ones that Steve's already outlined this afternoon. It's particularly around the complexity of needs and the provider market being able to respond to that in a timely way. The patients that we're describing here are patients with the most complex dementia needs in Sussex. Feedback from our community services. So the community services, one of the questions asked was, so what do your teams think of the changes? So our care home inReach team in Brighton and Hove say that they continue to provide close support to care homes. So they have a dedicated rolling programme of training and intervention and clinical support to all care homes, not just care homes that specialise with dementia, but supporting those homes in providing the right support, right interventions for those patients, and ideally preventing unnecessary hospital admissions. Social workers have reported increased travel time when arranging discharges, but I think it's important to remember that we're describing a very small number of people who have had to receive their inpatient care outside of Brighton and Hove. And we absolutely recognise the impact that that has. However, we're now increased our adult beds by 15 within the city, which means that those patients are now not receiving their care over in the far reaches of East Sussex, which is where they were previously receiving that in the independent sector. So there is a quid pro quo in terms of the impact on patients, families and staff. But I think it's important to say we absolutely do recognise the impact on people receiving their care outside of the city and the impact that that has on families and carers. And then just in terms of next steps before we move to questions, virtual wards. You may well have heard colleagues from our acute and community trusts describing virtual wards. We think that that's something that shouldn't be limited to people with a physical healthcare problem, and it's something that we think that we can expand for people with a dementia. And we're looking to pilot that in East Sussex and Brighton, working with our community trusts. You've heard me already describe the dementia services and where we're seeking to recruit and increase our community provision. And like I said, we're reducing the use of our independent sector provision for adult mental health patients, hence the fact that we've opened more beds within the city so people can receive their care closer to home. And the final point would be, we will continue to monitor the use of dementia and older adult mental health beds. We know the demographic of Sussex more widely is ageing. Obviously, that's not reflected within the demographic so much within Brighton and Hove, but it is not to say that we will just stand still. We can obviously continue to monitor the impact of the changes that we made. And more than happy, for Laura and I, more than happy to take questions.
Thank you, John. Do any members have any questions? Councillor Evans?
All right, thank you, Chair, and thanks for the update. Just at the end there, I sort of, my ears pricked up. Really pleased to see that you're reducing independent sector provision. That sounds like a positive thing. But also, can you say a bit more about how virtual wards work in this context? Because that sounds quite terrifying to me. You know, I've got very little experience with dementia, but I did about 10 years or more ago, someone in my family was in hospital with a badly broken thigh bone and was in a bay at Sussex County with a whole bunch of people much older than them with broken hips. And one of them had full-blown dementia and had been brought from a care home with a broken hip. And that was quite an eye-opener as to what it must be like caring for someone with dementia, even in a care facility, let alone at home, if you're an amateur, because this poor lady could not remember for more than 5 minutes that she had a broken hip and kept trying to get out of bed, and with all the resultant screaming and, you know, all the rest of it. It was absolutely nightmarish, not just for her, but also for the other patients in that ward. And how the staff, who were not obviously dementia specialists, they were on an orthopaedic ward, eventually dealt with it was by switching off all the alarms from that particular bay, which was also not particularly helpful, because it just meant that the people in the other patients in that bay and this poor lady had to just deal with the constant screaming and pain and all the rest of it. So it was just awful. Anyway, that's just one small example of how difficult dementia can be to deal with. And I just wondered what virtual wards means in this context, because it just sounds like a recipe for disaster to me. But
thank you. I think the first thing to do would be to reassure you that obviously virtual wards would not be for all patients. That's not something that we would look to explore for everybody on our wards. And I think you've gone some way to describing the complexity and of the needs of some of our patients. However, we recognise that virtual wards, and I'm sure the committee are aware of them as a national initiative, is something that we think that some of our patients may well benefit from, to support them to return home, to return to an environment of which they're familiar. But it would have to be clinically safe. And it would have to be done in conjunction, obviously, with family members and carers, whether that's paid carers or unpaid carers. The whole package of support would need to be taken into account. The virtual ward model is somebody receiving in effect, their inpatient care at home, and they remain under the care of secondary care specialists. So it's not just somebody's discharged home and discharged to primary care. They would have regular input from specialist nurses, and they remain under the care of a hospital doctor. So in our model, that would be a consultant psychiatrist with specialist skills around dementia, and it would be nursing staff with specialist skills around dementia. Alongside, of course, may well be packages of more traditional care. The benefit of doing it with our community trust colleagues, so Sussex Community Trust and the community wing of East Sussex Hospital Trust, is very few of our patients with acute dementia needs don't have physical healthcare issues alongside that. And we recognise that they have real expertise in providing support to people with physical healthcare needs. Similarly, they would say that we have expertise in providing support to people with cognitive challenges and memory impairments. So we feel that there's some real benefit to patients to being able to join that model up. But I would certainly wish to reassure you it's not something that would be suitable for everyone. And the presentation that you've described is not unusual on our dementia wards.
Yeah, I would just add that it's the importance of looking at all of these patients individually. For me, as a director of nursing, I really do love the idea of us thinking in terms of virtual wards across Brighton and Hove and trialling it here, but also considering our other demographics. The reason for me is I think it also allows earlier access. If we look at this particular group of patients and their complexities, as John says, in terms of the physical health, they will often come into hospital at a later point and then become quite stuck. So virtual wards can enable us to engage sooner and meet their needs.
Thank you. That is very reassuring.
Councillor Zadusman.
Thank you. How is Brighton and Hove long-term health strategy actively shifting power and resources to communities most affected by health inequalities, while building a more preventative, inclusive and climate resilience health system?
Can I just check your question? Is it how can we ensure that we're sort of shifting resources into more preventative space for the residents of Brighton and Hove? Thanks. Certainly happy to have a stab at that question, and I know our colleagues from NHS Sussex aren't here anymore, and that's something I think they would probably wish to talk to as well. So Sussex Partnership has recently launched an organisational strategy, and whilst of course that is very much focused on the needs of people with serious mental illness of all ages, it does have and continues to have a focus on population health inequalities, and it has a focus on prevention. It's well documented, isn't it, that people with serious mental illness have a number of health inequalities, and as a result, they have a lower life expectancy. And we are trying to tailor our services to minimise that. So if I think about the last presentation, investment particularly in our most acute end of our CAMS services, so really working with children and young people who are at risk of considerable harm, risk of eating disorders, risk of high levels of suicidality. One of our particular initiatives is around suicide prevention. And Brighton and Hove obviously is a national outlier in terms of suicide. So we have, working again with our public health colleagues, a very detailed and focused interventions around suicide prevention. And there are a number of things in that space. I think it's fair to say, though, in the time we're all experiencing restraints, capacity restraints, much of our attention is drawn to the most acute end of what we do. We're developing neighbourhood mental health teams. You will have heard, the committee will have heard previously around integrated care teams, and neighbourhood mental health teams is our version of that. And that is really around how do we join together our specialist services, primary care, adult social care, and the community and voluntary sector to ensure that we intervene as early as possible and that we offer our residents a holistic service. So we're not waiting for people to become poorly until they're referred to us. We're really seeking to intervene. So within a sort of constrained environment, we're looking to adapt our services so it's people's intervention is as early as possible. I hope that answers it to some extent. I think it's a much longer question.
Thank you. Councillor Gittell.
Just before Gary, just to mention, just to come in on that and just to identify that, yes, NHS Sussex, since the government launches neighbourhood health guidelines, as some of you would have been aware, we've been working really hard with all of our providers to ensure we've got a much more focused community offer. And I think, as John mentioned, that includes mental health, but also physical health. And part of that is bringing them both together, because too long we've had some of our services working in silos, and that includes the multiple really good services that are out there. If they work in silos and they're not offering the best possible care for communities. So that's part of the neighbourhood health offer, is to bring mental and physical health together, but also adults and children and young people's health together. And that will be part of a multidisciplinary team set up in each neighbourhood to be able to offer what that neighbourhood needs. We're robustly using more data-led approach as well to see whether it's about inequalities that people face, whether it's more related to cardiovascular disease and the serious mental illness, and or obviously looking at data that relate to whether it's gender identity, whether it's a sort of ethnically diverse community, whether it's an access challenge, or whether it's just an interventional challenge. And yes, part of that is part of our neighborhood health plan, and we have an approach that we'll be launching this side of winter, so hopefully in October.
Thank you, Chair. This is an observation as much as anything, and with you being here, I'd like to find out whether this is no longer the case. My late mum came to stay with us in Brighton, and I've just looked it up. It was in a World Cup year, so it must have been 2006, and she had a UTI. I mean, she already had vascular dementia, and she had the UTI, and she was admitted to the county hospital. And she was in one of those horrible wards in the old building where all the beds were round the edge of the, Anyway, she was quite a feisty person, and so that made her dementia made her more bit of a, a bit noisy. And I actually got a phone call from the ward to say, your mum's upsetting people, can you come and get her? And because it was a general ward, and there were a couple of people there, and she was going over and looking in their lockers and up seeing things and shouting at things that she was, that she thought she was seeing. But I was like, what am I supposed to do? You are the hospital. And I'd like to be reassured that sort of thing doesn't happen, because I was really quite upset by that, as you can imagine.
Yeah, I think firstly it's really awful to hear that was your experience, but as you say, it's not. Sadly, it has happened previously. I think what I would start off by saying to you is, over the last 3 years, particularly in Sussex and nationally, there's been a big move to support parity of esteem and improved experiences for those with dementia, but also with SMI who use our acute hospital settings. So if we look at UHSX, they have around 2 years ago, they created a new role, which is a head of nursing for mental health. That particular role works on the parity of esteem aspect, so ensures that there's the educational piece for our general nurses who may not be used to working with dementia. There's also lots of training now that's available for general nurses. There's standards in terms of dementia care that should take place on wards. One thing I would really say to give you the assurance is, we often, it's recognised that for those with dementia that are admitted onto general wards or mental health wards is profoundly confusing and difficult for them. And we really recognise that as a trust, which is why we are keen to move towards a more community-based model and a supportive virtual wards offering. So that would be my assurance to you.
Just to add to that, the experiences that your mum had, so whilst patients on our wards may present in a similar way, there's certainly something about the environment. So the environments of our dementia wards are very different from what your mum experienced at the county hospital. That's obviously an acute medical hospital. So our wards are designed for people who have dementia needs to be safe. So they're not corridor based. A lot of the ones in Worthing are based in a circle. So actually you could, I don't like the word, but you could continue to walk around and people have their own rooms and they're obviously assessed accordingly. So the environment's different and that would hopefully be a mitigation to be able to manage the behaviours that challenge.
Jeffrey. I mean, the focus is on the patient, obviously, but people I know who have family members who have dementia, quite often they take on the caring responsibility themselves. And I just wonder what arrangements there are within this new model to give respite care to those people, often quite elderly themselves, and under a tremendous stress. So with fewer beds, where someone could be admitted for a short period, what kind of capacity does the system have to, give a break to those people who are taking on the caring responsibilities at home?
Thank you. We're very fortunate in Brighton to work so closely with Steve's teams in adult social care, so that the council's social workers who look after this patient group are seconded to Sussex Partnership Trust, and they sit within our services, so we run an integrated service. Therefore, we work, local authority supports our patients to access respite care in residential or nursing homes if that's appropriate, on occasion to receive that care within their own home so carers can receive support. Similarly, we work with community and voluntary sector, Alzheimer's Society and other organisations who provide that care for short periods of time. So there is provision. It's predominantly offered within the sort of commissioned social care market, but it's available. And yeah, like I said, the social workers who sit with us often will access that for families. I don't know, Steve, if there's anything you would want to add.
Thanks, John. Yeah, as John said, we work in an integrated way with our colleagues in Sussex Partnership, and I guess we've retained a number of services within the council. So we have Arlen Lodge in Woodingdean, which is a 24-bedded residential dementia service that offers specific respite support for carers of people with dementia. We have extended some of the reach of that service as well to support hospital discharge and prepare people back for going home. So there are a range of services that we commission, mainly in the independent sector, but we've also retained some of our own council services for that purpose because they're sort of fairly specialist in their nature.
Are those budgets protected? Because everything is under stress in the local authority. I mean, is that a ring-fence budget for that respite care?
Arlen Lodge has not appeared on any savings and efficiencies plans this year for the council. In fact, it's received some additional funding to help with that enhanced service. So, I mean, as you say, Jeffrey, all council services are under a degree of stress. But in terms of this year, Arlen Lodge in particular received additional investment. So that stuff's moving in the right direction.
Don't have any further questions. Councillor Hill.
Just more of a procedural question than anything, I suppose. But at the last time this was brought to committee, we had some questions that were about the quality impact assessment and the equality impact assessment, which are two separate things apparently. And I think thanks to the Older People's Council, that has eventually been sent to members. That was done in September 2024. I think ideally we would have liked to have seen that come with the item when it was brought up last year. So I'm wondering, obviously I understand there was a need to change the language in it to make it more accessible, and so there were challenges there. But it felt as though there was maybe some issues around the sort of transparency when it took so long to kind of get it out. So I'm wondering if there's anything that kind of can be learned from that. And yeah, obviously, thanks to the Older People's Council, and I hope you can also engage further with them with this also. Thanks.
John.
I'm happy to come back and thank you, Councillor Hill, and Mo. If I don't answer the question fully, do come in. Councillor Hill's absolutely right. When we last came, we made a commitment to share the quality impact and the equality impact assessment, and apologies for the delay in getting that back to you. That took longer than we should have done. I think it's really important to say we did not change the content of it. We said that we wanted to make sure that the language was suitable for people that weren't embedded within NHS jargon, and we wanted to make sure that it was as accessible for members as possible, which was why the delay in getting that back to you. I had a very helpful meeting on Friday with Laura's colleague, who's the Managing Director for Brighton and Hove Services, with representatives of the Brighton and Hove Older People's Council, who gave some very helpful feedback on quality impact assessments and equality impact assessments, and making sure that they were suitable, transparent, reflected the needs of the population. It is important to say that the processes that we described to you last time when we came and presented them did go through our organisational processes around EIAs and QIAs. Similarly, they went through the commissioning structures within NHS Sussex before we came and presented it to you. So it did have that level of scrutiny. On the back of the feedback around this case for change and some of the others, we have made changes internally to our processes around quality impact assessments and equality impact assessments, not least to ensure that the versions that we use are accessible and understandable to colleagues who are perhaps less well versed in NHS jargon. And again, I apologise for the delay.
Just to add, I also felt that having read those documents, I did feel more confident about the change that was made. So I think that in some ways, having not had it at the point at which we heard the item, but without that information, I felt more sceptical towards the proposals, and actually reading it did reassure me, because it does take a quite objective approach and goes through things in a helpful way. So yeah, thanks to helping in sort of working with the Older People's Council as well with that also.
Thank you. Councillor Parrott.
I wanted to ask about trauma in dementia, and what work or any work is being done around dementia patients having episodes of trauma and reliving trauma, because obviously as things start to unravel for them, hidden memories or memories that have been pushed away for a long time can come very much to the fore, and that's a very, very complex issue for a family to deal with when they suddenly start hearing trauma that's previously been unrecognised or unspoken about. For example, I have a neighbour who's 83, 93, in fact, yesterday, 93. She's very, very dear to me, and I've been involved in the wraparound care that her family were providing for a long time. She now has a full-time living carer, but for a long time we were very involved in that. And we've had episodes of her talking about domestic violence, for example, in her marriage, which her children have found incredibly difficult to deal with. And so, as I said before, I'm a psychotherapist, so I've been able to help and support in that, but that they're just very lucky that they happen to have me as a neighbour, and Carmel is very dear to me, so we've been able to manage that. But also a few weeks ago I met with Switchboard, and one of the things they were talking about was dementia in the LGBTQ plus community, and how that is on the increase now, and that, again, they're seeing rises in trauma being expressed at particularly in the beginning stages of dementia. So there's clearly, for the patient or for the person, that's really, really complex and really difficult. For the family, it's incredibly difficult. They're then dealing with that. And also for staff who may be picking up some of that as well. So I just wondered if that was part of your work.
Yeah, I mean, trauma is it's big on our agenda at the moment across all of our community mental health services and also our inpatient. So it's not just specific to dementia. We are really fortunate in Brighton and Hove. We have what I would describe as an excellent SOAMS team across the piece. That's our community older adult services. We are really lucky in that we have embedded psychologists within those teams. We have senior nurse practitioners. Trauma-informed care is at the heart of everything that we do in Sussex Partnership Trust. We don't limit that to say only those with neurodiversity or those with complex emotional needs. That also runs within our dementia services. So as part of any care planning, risk assessment and models of care, trauma-informed care would form the backbone of it. So every patient or every service user that comes through our services would receive trauma-informed care.
Councillor Simon.
Thank you, Chair. Yeah, I'm interested to know, obviously you're talking about moving towards a more community-based provision, but I'm interested to know where the demand is. So if you literally asked people, what would you prefer? What would they say? And do we know? Do we ask them? and we may not always be able to deliver what they prefer. But I'm interested in that kind of, is the demand changing from residential to home-based, community-based, virtual, whatever you want to call it, care, or is there a shift, or not really? I'd be interested to know. Thanks.
Thanks. That's a great question. In Brighton and Hove, we've seen a number of patients admitted with acute dementia care gradually reduce. And I think that's for a number of reasons. We could speculate on the demographic issues around that, but I think it is a reflection of the intensity of the community support. In terms of people's wishes, on the whole, people want to stay at home. That's our experience. However, as colleagues mentioned, there's definitely a breaking point for family and carers, and that is something that we absolutely have to recognise. There is also a similar breaking point for the residential and nursing home market. So we experience a significant number of our admissions come from residential and nursing homes, and that's not in any way to criticise the care that they provide. It's around the complexity of the patient needs. Would they wish to continue to look after, to support those patients? Absolutely, I think they would. But sometimes I think they feel that they need specialist care, specialist assessment, specialist medication regimes. I think a number of our patients may not needed to be admitted into hospital if there were a different and more intense community offer. But often it's about the lack of rather than the need for, if that makes sense. And so actually the purpose of the admission can be quite short. Specialist assessment, reset a care plan, reset a treatment regime, pharmacological and obviously other treatments to support a return back to a community setting. Does that?
Any indications on members? No. In which case, I'll indulge myself and ask a couple of questions myself. We just talked about community support and making enhancements with our community dementia services. Can you just expand a bit to say how we could enhance them to provide a more robust service, given that, as you say, a lot of people are coming into the acute services from the community? How is our services better prepared to enhance the ability to keep people in the community? That's my first question. And the second question, we talked about the changes moving from one bed provision to another, and I just would be interested to know if there's been any unintended consequences because of that observed in our demand on our emergency department usage, or our mental health crisis presentation teams. Has there been any unintended back? And then finally, one last question. You did talk earlier, John, about how we would regularly keep a watch on this. Can you just talk a little bit more in detail about how you'll continue to monitor the service changes on equity? Thank you.
I'll start and then see if Laura wants to come in. I'll cover those in reverse order, Chair. So we monitor very closely all of our inpatient hospital usage, the numbers of people that come into hospital, the length of time they're there, the diagnoses, the treatment plans. We have a very detailed data sets that we look at internally, and obviously have to work with NHS Sussex and NHS England. And in terms of our overall demand profile, we monitor that particularly closely to really understand the patient profile that we're admitting. Patients, what percentage of patients are known to a community team before they come into hospital? What aren't? What's their first presentation? All the sorts of questions you might anticipate. And that the same applies for adults and older adults. Unintended consequences. We haven't seen any unintended consequences yet. There are, of course, a small number of patients and their families that have received their inpatient care outside of Brighton and Hove. But in terms of people waiting considerably longer to come into hospital than they were, we haven't seen that yet. And we haven't seen that impacted on the county hospital. We know that there are people waiting in the county hospital for inpatient psychiatric care for too long, but they are adults. They're not waiting for inpatient dementia care. How could we enhance our services. So when we presented last time, I think we described the suite of services in Brighton and Hove that support the older people's mental health issues, and Laura's touched on some of them. We do have a dementia crisis service. We do have access to the respite services that Steve's described, and we do have a care home in-reach team. The area where I think we will be able to enhance our service, and somebody used the phrase earlier, I think it was one of the members on this side, was around frailty. So if we have a specialist service that is supporting a relatively small number of people with complex needs. There are obviously a greater population of older people than just the ones that we look after. And how can we bring that expertise closer to primary care, closer to the acute hospital, closer to the community trust services that work with the patient group, again, who may be in the early stages of a dementia or also have other mental health issues. So how do we make that a more combined and more holistic and less specialist over here offer? That would be, I think, is the area where we will be able to enhance our services.
Fantastic. Thank you for that. Do I have any indications from members? No. Well, thank you very much for helping me through my first meeting as chair. Thank you very much. And thank you all for some very interesting and forensic questions. And thank you coming along again and presenting. And on that, I will call this meeting to a close. Thank you.